Hello,
Hello.
and welcome to A Seat at the Table, Dr. Tia.
Hello. Thank you for the invitation to join the conversation this evening.
You're very welcome. While our friends are filing in, I see you guys coming in um, to join us this evening for the conversation. I want to preface this conversation with this is kind of like you guys being a fly on the wall between a conversation with a doctor and an attorney, just across several different topics that we want to cover, to give some perspective on how we analyze certain things, sometimes the same way, sometimes different way, in a different way, and how we work through our analysis on these things, and then to provide you with some um, I guess, advice on ways, because we talked in this group before, Dr. Tia, and I'm going to introduce you in a second. I'm just letting people show up, and they're filing in, about as women and Black women, which primarily the ladies at the table are, challenges that we find in trying to advocate for our health and ourselves in our own healthcare needs and treatment. And I'd love, to just share some ways that we can better do that as women and men. We do have guys at the table too. We're not leaving them out, and they certainly have to advocate for their health as well. But just to share some ways that we can better advocate for our health from a physician standpoint, what will be more effective for us. So, good evening. I see the folks saying hello. I love the look. What look, girl? This is just a shirt and some glasses. Maybe you're talking about Dr. Tia. But thank you. Um, And I want to introduce you all to a dear friend of mine. We go back a ways. I can't even think of how many years, a couple of decades at this
Yeah,
point.
plenty
You all
plus.
know when I bring somebody on, I've known them long enough. Um, and we are dear friends. I respect her opinion. I respect her um, way of thinking about things. And she is a board certified OBGYN. She is who I would almost always call before any of my appointments to say, hey, da 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 da. Um, and she is also the director of public health for a major county um, health system. We won't be, I won't be specific about where, um, because I just don't think it matters. And she's just a genuine person who, when this came up, this particular news story came up in our group, I gave an opinion that was a very lawyer opinion. This will settle. And she reached out to me and she said, Let me help you think about this, a little more holistically." And the conversation was so rich that I asked her if she would be willing to obviously not have the same conversation that she and I had, but have a conversation about when things happen and things don't go as planned, some of the who, what, when, why, and where with the table. And she was willing to do that. So I asked you all to come with your questions, with your open minds, because my mind was, by the time we got off the phone, my mind had expanded. I had learned something. And there aren't many people in this world that can check me. She's one of them. Because I know she knows what she's talking about and I know her heart. So I wanted to share that with you all tonight. And I appreciate you, Tia, for being willing to. I mean, it was an immediate yes. It wasn't like, um, I'll think about it. It was, of course, for being willing to come sit at the table tonight and share with everybody on, you know, something that's really important. Like I said, we had a conversation about many of us go out and we seek out our physician and we made a joke. It was in a different group that I was in. We made a joke that we want our doctors to look like us. And I was like, I prefer they have locks because I know they have a certain level of self care and holistic and just a certain world view that I, appreciate. And so here's a sister physician with locks, y'all. Let's do it.
Thank you, Dorna, for that grand introduction. I appreciate that from the bottom of my heart. And you know that and we go way back. And I have so much respect for you and the work that you do and how you do it and your heart. I think that's how we really connected. And I would not do this particular topic with anyone else other than you, because I know that I'm in good hands, and we can really get into it safely and handle what is a very delicate topic um, with grace and respect.
Exactly.
Yeah, and I'm looking forward to having this conversation and to answer questions, because it's really important to have a different perspective when we are presented with issues or situations in the media. And sometimes, and I'm just jumping right in there. Do you want me to jump
Yes.
in?
Yeah.
Okay.
Let's jump right in. Everybody knows what we're talking about and why we're here. So yeah, jump right in.
Okay. So, when we were talking about it, the first thing, honestly, from a physician's point of view, and I'm not taking any sides here, I'm just speaking about from my personal experience first, what I thought about from as a physician. And then Dorna, just chime in anytime when you want to, give your perspective as an attorney and how you looked at it. Um, I think though that one thing that we can agree on is that both of us thought, wow, that was just gut wrenching,
Yes.
to read that headline and to put yourself in that position for that young couple, yet young mother and father,
Right.
devastating that had to be.
Right.
That was the first thing that gripped my spirit was, wow, this is tough. This is a hard case. Um, the next thing my mind went to was, wow, everybody that touched that patient during that visit was probably traumatized, because no one walks into work today and says we're going to be this is what we want to happen. Everyone wants to go in, especially in the field of obstetrics and gynecology, and say and have all the feels, the good feels, because that's the best part of what we do in this area. um, so to see that headline and immediately have a gut reaction, an emotional reaction. The next thought of my medical mind was, well, what happened? And I think a lot of people went there too. Well, what happened?
Yes.
And um, and so you get curious and you read a little bit more and you read a little bit more and you start understanding what um, you start to understand the story and the picture, and it starts to form in your mind. The difference, though, for me was I have the medical background to know that there's more to it than what's presented, not at all discounting what was said and not invalidating anything that was reported, but understanding the nuances with deliveries and how I don't want to say dangerous, but sometimes they can be very scary because you can end up in obstetrical emergencies where you have to make quick decisions that are life saving decisions in a matter of seconds. And no one likes to be in that situation. We are trained to be in that situation and to handle them appropriately. Uh, but every obstetrician's nightmare is to end up in a situation where they're in an obstetrical emergency and the outcome doesn't turn out the way that we want it to, regardless
Right.
of what it is.
Right. Right. And that was not, as a lawyer, when I looked at it, I literally just thought, however they got there,
Mm-hmm.
this is bad, whether it's bad press or bad behavior, right?
Mm-hmm.
This is the kind of thing that won't go to trial. That just was where my head went, my training, right? And your head went to, wow, nobody got up this morning with this outcome in mind.
Right.
Um, this is every physician's worst nightmare. What happened? We both had the wow, like you said,
Mm-hmm.
and I didn't even really go into what happened. My mind didn't care yet what happened. My mind went to that's what happened and what happens after that. So I thought that was an interesting um, balance, I guess, in the way that my mind went. You went to what happened to a certain point, and my mind went to what happens after that. And between the two of us, we kind of cover everything. But thinking, I just thought it was intriguing that we both thought about it completely differently from our training, first of all. And then I appreciated, and again, we're not, I don't want to ask Dr. Tia to talk about a specific case because it's not her case and she's not seen these files. She's not reviewed this at all. So you guys, I'm going to not put her in a situation where I wouldn't want to be in talking about some facts I don't know. So we'll talk about what we'll talk about broadly what can go wrong or what could have gone wrong or what can go right or what is going on when there's a delivery that, as a mother of two, I've had two children, but I couldn't tell you how. I don't know what was going on. God and the doctor and nature did that, right? So to give us some background, because Tia, I'll be frank, there is a feeling among Black women, and I don't know if it's other women. I'm a Black woman. I know what Black women, we talk about, that Black maternal health is not at a good place right now, that Black women are at some sort of disadvantage right now when we go in to have our children. And it could be, from watching what happened with Serena or watching the rates, knowing the rates of maternal death. It could be any number of things that kind of make us feel that way, but we immediately feel like we've got to do something to make sure that we're not in a bad situation. So when a news story comes across with a sensationalized headline and, the word decapitation in the headline, it triggered people, including you, and me. And you and I, we just want to dig a little deeper and get under the hood on it. So let's get into it. And if you could explain whatever you want to explain about, I think you used the word shoulder dysplasia. Now I'm gonna caution you guys in the audience. You think I have a bunch of knowledge and know a little bit about everything? This woman, she will call me and we will just be talking, and she just knows so much stuff. So this is going to be a very rich conversation because she knows. And I end up thinking, how does she know all that? She hasn't even been doing that for that long, or it's been a while since she's done that or whatever. But she knows her stuff. And she's going to use some words that none of us know what they mean, but she's going to explain them and we'll understand it by the time she's done. So I think it was called shoulder dysplasia, dystopia. I don't know. Tell me what
So shoulder dystocia.
I combined two words. Okay.
That's okay. But I want to get into the maternal health topic really quickly and just say one thing about that. And that is one of the most important things about the maternal health is disparity that we're seeing with Black women is that the rate of increase of mortality and morbidity that's like risk almost, the risk factors for something really bad happening and then someone actually dying are really because those situations are preventable. That's the rub, is that they're preventable. Death from preeclampsia, death from, I believe we had a former Olympian who had, I think there was some preeclampsia or something going on with her, who died recently. Blood clots, excessive bleeding after surgery. Those things are preventable. And there's so many, we can go into that too at some point if we have time at the end. You can dig into that a little bit too, because that's a societal issue, systemic issue, implicit bias issues, knowledge, advocacy. We can get into all of that. But we're going to go back to the shoulder, what you call it? I'm going to call it what it is, shoulder dystocia.
Yeah, you used the right word.
A shoulder dystocia basically is when the shoulder gets impacted upon delivery. So what happens is for delivery, the baby's inside the woman's uterus, and the baby's cephalic. Normally you can have births where the baby is breech, but in this situation, we're going to talk about a vaginal delivery with the cephalic baby, meaning the head is down. So the head is down, and I thought about having a little pelvis here to explain it, but I don't have that. So
we all have a pelvis. We'll just picture our own.
Just picture your own pelvis and try some good visualization techniques here. So you have this baby's head, they're entering the bony pelvis. And the head basically kind of tucks in. We call it flexion, and it engages first with the bony pelvis, and it tucks in, and it starts to descend down the birth canal. As it's descending down the birth canal, it has to turn around a little bit because the shoulders are have the largest diameter on the baby, right? So the head is, big, and then you have the shoulders that are wide. So the shoulders have to kind of maneuver a little bit as it comes down the vaginal canal. So the shoulders turn internally first, and then once the head is down near the perineum, the head extends up, and that's where the perineum, the head of the baby is sitting on the perineum. You can see it. You've ever been in delivery and someone says, I see the hair. And then it goes away because, the woman has to push again. But,
Mhm.
see the head there's on the perineum, and that's when the baby's extending the head out. And after that extension, the head comes, once it's delivered onto the perineum, the
Mhm.
head turns. So it turns, and it's called restitution, and that's external rotation. So all these things have to happen. They're called the cardinal movements during labor. They have to happen for the baby to deliver appropriately. When the shoulders are coming down the birth canal, the anterior shoulder, when it turns, sometimes it can get stuck behind the pubic symphysis. And we all have a pelvis. There's this little bony part there. And that's your pubic symphysis. And the shoulder, the anterior shoulder, can get stuck. So imagine the baby coming down this birth canal. And instead of the shoulders being like this, the shoulders are like this. And that's
Okay.
normal. So it went from this way to this way, right? When it turned internally. Well,
Because the
imagine
pelvis is wider this way than it is this way. Otherwise, we'd all be more square than we are. Those of us
exactly,
that are square. Okay, got it.
exactly. You got it. You
So
got it. And
your hips are left and right, and your baby's shoulders need to be coming out left and right as well.
well, initially, not initially, they're going to be when it goes. So your pelvis has the top and the bottom, the opening,
Mhm.
the inlet, and
Mhm.
the outlet. So when it
Mhm.
goes to the inlet, the shoulders are left to right because it's flat, like you said. That's the widest diameter. So you got it. The shoulders, the widest part, goes through that way. And then as the baby's descending down, if the baby tries to stay in this position, then there's going to be a problem typically,
I
usually,
see.
because it has to turn in order to fit in that outlet. So the inlets from the inside, the outlets goes outside through the vagina.
Got it.
So if it doesn't turn, that's one reason the shoulders can get impacted because it doesn't make that turn so it can fit and come
Got
out.
it. Okay.
And when it turns, typically when it's traveling down the birth canal, the posterior shoulder is a little bit higher than the anterior shoulder. So if for some reason there's a wide diameter here, then the anterior shoulder can get stuck behind that pubic symphysis.
Got it.
All right. And so that's a shoulder dystocia. When shoulders are not able to pass through that bony pelvis appropriately. And the head already does the extension. It's sitting on the perineum, but it can't go any further because the bony part is stuck. The bony part of the baby is stuck alongside either the bony part of the pelvis or the skin and tissue, right? Because it's just too wide to make it through. It didn't descend down appropriately. So
Okay. Is the physician doing anything at this point, up to this point, or is this, when you're saying cardinal movements, is this God and nature and pushing, or is there any interaction or intervention, medical intervention happening at this point to the point that the baby is on the perineum, I think you said? Look at me just illustrating.
yeah, you got it. You got the whole thing.
I remember that part.
Just resting there, right?
Yeah, yeah.
So, you're like, get this baby out, and it's just chilling.
Please.
So yes, actually, there isn't anything. That's nature. That's nature. God created us to be amazing beings, and so that's nature. That movement process for the baby to deliver. Meanwhile, the entire time the uterus is contracting, so that force, the expulsion force is helping to push this along too, but the baby has to move in order to fit. And that's basically what it is. It's all like
Okay.
physics. And you're following along just right. This is perfect.
Okay.
So
I'm
so
I'm remembering.
and so once, yeah, yes. So once the head is delivered, If there's a shoulder dystocia, when the mother pushes, the head kind of comes out and then comes back, goes out and comes back in. So it's we call it a turtle sign, and no matter what, it's not coming out. And sometimes the head can be out a little further, and you can try to put some downward traction on the head to move to deliver the anterior arm, and it doesn't work because the shoulders are stuck. So let me get to that part real quick too, in terms of what a normal delivery looks like. I'm going to complete that process. So once the head is on the perineum and everybody's getting excited and the dad's getting ready to pass out on the side of the room,
Right.
um, the obstetrician takes the head and applies gentle downward traction on the head, but we try to keep the spine aligned as we're doing this because we have to get that anterior shoulder delivered. And as long as it's beyond that pubic symphysis, it delivers, it comes down, and then you lift up to deliver the posterior shoulder. And then you have a baby, basically. One more big push, and baby just comes out and splash of water, and everybody's happy and crying and all that wonderful stuff. That's
Right.
what we see when we wake up in the morning and we are going to work.
Got it.
With a shoulder dystocia, what happens is once I explain that the shoulder gets stuck, you have about 5 minutes to figure out how to get this baby delivered before there's a severe risk for asphyxiation. Basically, the baby won't be able to breathe, and so there could be neurological deficits after that, or ultimately death if there's the deprivation of oxygen for an extended period of time.
And that's what struck me. Like, okay, when I have a novel issue, even if it's something I've been trained to do, but it's never happened to me before, I have way more than 5 minutes to figure it out. I have like 5 months. So I just started thinking, my goodness, 5 minutes. And that's when my heart and mind started to turn to like, there's more to this than neglect, or there's layers to this, but it's an emergency at that point is what I gathered.
It's an emergency, exactly. And what happens in that situation, you have a couple of different options, and those minutes feel like hours when the baby is, as we in layman's terms say, stuck. It feels like hours because now you're forced to have to go through that process of trying several different maneuvers to deliver the shoulders so that the body comes out and the baby is healthy. And then so when we talk about maneuvers, there's rotational maneuvers that we can do. We can place. If we have an assistant in the room, they can help flex the legs back, and that changes the diameter of the opening and provides a little bit more space for that posterior arm to come out and can be delivered.
Okay.
And then you can deliver the posterior arm. And just stop me if I'm getting too detailed and all that stuff.
Not for me. You guys following? I love the detail because it helps me understand. And they're not commenting much, which means they're following along and listening. You guys, you want this level of detail, or you want to? Yeah, they're following. Okay, perfect.
So we call it the Robertson maneuver, where we hyperflex the thighs back and open up that space, and that gives room for the baby to come out. The other thing, as I mentioned before, is the rotational movements. Fortunately, I have thin fingers, and so when I had to deal with shoulder dystocias, it was easier for me to get my hands in there and try to rotate the shoulders well enough so that the baby's body can fit through the opening. The other is the posterior arm, and so you can go inside the birth canal and link up with that posterior arm and pull it out, and that's an art to doing that as well. Sometimes there's a risk for fracturing the humerus of the arm when you do that.
Of the baby's arm. So the posterior arm, if I'm the baby, and this is stuck, and this is this anterior and this is posterior?
Which one is stuck?
The one that's up higher.
Yes, if that's the anterior stuck,
So
yes.
pull this arm out, and maybe I'll do this. Is that?
Yeah. So what's going to happen is we have to sweep down the humerus here. The humerus is this part, this long bone here in your arm. And so you sweep down, and you have to get to the elbow, and you kind of pull it up this way so that the hand comes out, and sometimes you can grab the arm. Sometimes the baby's already coming out like this, and so you can pull the arm up that way. But when you're
Ouch.
going down to get that elbow to kind of flex the arm and get, sometimes that humerus can get fractured. And
Okay.
then, yeah, that can happen. And then now, if none of those procedures work, another thing you can try is draining the bladder. So if the bladder is sitting in the vagina because it's full, you can see if that can, if you drain that, if that will open up the space a little bit.
The mother's bladder?
The mother's bladder, yes.
Okay.
Yeah, the mother's bladder.
So in 5 minutes, you're trying all this.
You're trying all this.
Okay.
And we haven't even got, so now you're, after you've done this, I don't know, for maybe 3 or 4 minutes and nothing's working, the baby's still like really stuck, as I said earlier, then you start to have to go to some last resort options. And those include like intentionally breaking the baby's clavicle. And the clavicle is like right here. And if you break that, that collapses the shoulders a little bit and provides space so that the baby can come through. Of course, there's risk for injury to the lungs, and anything else in space there. So that's dangerous. Another option would be to do something called the Zavanelli-O'Leary maneuver. And that's where essentially you try to reverse all of the cardinal movements that I described earlier, which is why I went into that level of detail. Because if you do that procedure, that's like almost last case scenario. You're just trying to save the baby. You literally have to take a head that's already extended out and sitting on the perineum. And if it's already restituted or externally rotated to the side, looking to the left or to the right, you have to try to rotate it back so it's looking down, and then flex it back up inside the perineum. And at that point, go to the operating room and do a hysterotomy and deliver the baby through that. Either you can try to make some turns inside the uterus. So it's kind of like a cesarean section, except for instead of delivering the baby through the incision you made on the uterus, you're trying to do another internal turn, and then the baby can be delivered vaginally. The other case would be trying to deliver the baby through via cesarean section. And the last option, which hasn't been done very often, is the separating the pubic symphysis.
Whose? Mom's or the child?
Moms, yes, mothers.
What's the pubic symphysis?
So that little bone there, we all have a pelvis, but there's like a bone there that it has cartilage tissue in the center, and it connects like the frontal part, long bones of the pelvis, and you can fracture that in order to create more space.
Got it.
That one isn't well documented because it's so I don't want to say, yeah, ouch. And then the maternal morbidity and mortality after that can be severe because you're literally intentionally breaking the pelvis. The Zavanelli maneuver is extremely rare to perform as well. We learn about that and we talk about it in theory. We understand what that is, but to actually have to do that is something that most of us never really want to do, where we need to do those last resort, have to consider those. So again,
somebody asked a good question. I want to poke it in. And I don't know if you see these comments, but they are not loving. It's not a loving topic, but this is like really interesting. I can't close my mouth. This is so interesting. But one of the questions is, are there contractions going on during this 5-minute period?
Yes. So there are a couple of things that are happening. When we identify a shoulder dystocia, typically we ask the mother to stop pushing, because if she continues to push, that can worsen the impaction. So we want the mom to stop pushing until we get saturated, where we can do either one of those to try to dislodge the anterior shoulder or to deliver the posterior shoulder before she starts pushing again. Obviously, sometimes there's a a natural urge to push that you can't stop that urge, and so mom might still push. There are other instances where we can give a medication to help the uterus relax so that she's not pushing during this time. But again, you're going through this entire thought process in 5 minutes.
And the mother may or may not have had a what's the
Epidural.
word? Yes,
Correct. If she
may not
hasn't had
have
an
it.
epidural, the
Jeez.
ability to get her to stop pushing is going to
Yeah,
be next to none because that's so like just primal. That's how we were made.
involuntary. Yeah, I remember thinking, what is my body doing? I mean, it was the first time, not the last time, but the first time that my body was doing something that I had never had it do before, and never experienced. And it's like, what? What is happening, and how long is this going to go on? You don't know what's happening.
Yeah, you don't know. You can't control it. It's just happening. It's involuntary
Right,
unless we give a medicine to stop it.
right, right. Okay. So pick up where you were. I just wanted to kind of understand kind of what's happening with the mother at this point, if she's had an epidural or if she hasn't, or what these movements are and how they're happening.
So at this point, if you've reached a point where you're considering or actually implementing a last resort option, you're either near 5 minutes at this point because you would have really worked on those other maneuvers. And again, this is in theory, right? I'm not saying this is fact, but more than likely in cases where you have to resort to those options, you've tried everything else and you're either near or at 5 minutes or beyond it. Um, so if you get beyond 5 minute, 10 minute mark, and this baby hasn't is still stuck, and has been suffering with being asphyxiated, then the likelihood of the child surviving is very low at this point. And if the child does survive, then the likelihood of having severe neurological deficits would be um, pretty evident.
Right.
So that's kind of the process, and these things are really scary. How do you know who's going to have a shoulder dystocia? Technically, you have to be prepared for every single delivery that this could possibly be a shoulder dystocia. There's some data to say that if you've never had a vaginal delivery before, then that could increase your risk for shoulder dystocia. If you have macrosomia, if your baby is macrosomic, meaning the growth is greater than 95th percentile or 90th percentile, actually. The torso, we call it abdominal circumference when it's measured with the ultrasonographer. If that's greater than a 95th percentile, there's likelihood that you may be at increased risk depending on how your pelvis is made for to have a shoulder dystocia. And then that's something we haven't talked about either. There, not every pelvis is shaped the same way. We all have one, but we may not have the same one, like the same shape, right?
Yeah, like I wonder if you come into your OBGYN or your GYN or your OB, whatever, at this point, do you guys go, okay, she's short, she's tall, she's wide, she's narrow? Does that come into play as part of the case? It has
Yeah.
to, right?
Well, I'm not speaking to that particular case,
No,
but
in general.
in general, yeah, it does. And it's kind of it's more anecdotal than it is written in the books. As far as evidence, it's based on years of experience and kind of seeing things.
Hmm.
And a lot of older physicians that I've worked with really believe this too. And basically, if you have someone that's a shorter stature and is more obese or overweight, and say, for instance, if they have a morphology that's more like an apple, than compared to a pear. But those are all indications of possible insulin insensitivity, like gestational diabetes or regular diabetes, more so gestational diabetes. Someone who's obese or has that profile, physical profile, could likely be at increased risk for that. And we know that women who are obese have increased risk for having, can have an increased risk for having a larger child whose growth, fetal growth that is larger than normal.
Right.
And those who have gestational diabetes also can are at risk for macrosomia, which is excessive fetal growth during the prenatal time period. But the most important part about that growth is where it is, and it's normally the torso. So,
Got
and
it.
that's what makes it. So, when you see patients who kind of fit that physical profile, you don't want to say that patient can't have a vaginal delivery, not by any chance at all. But that is something that you think about when you go into the delivery room. Like, okay, this is what I'm working with. This patient might have a shoulder dystocia,
Mhm,
just
mhm.
based off of. So you're looking at the labor pattern. Is this a normal labor pattern? Are they progressing appropriately? There are so many other parts of the story that you would have to put together once you come into the room when the nurse says the mother is ready to deliver, or if you've been laboring with your patient the entire time. Once the active delivery portion starts, that's when all of that information that you've been putting together about that patient's care has an impact on how you make your decisions and when you decide how long you're gonna, try to push all those things. If you're pushing, the baby head just never comes down, and you think, well, she is kind of short, and she is, or she is tall, but she's really skinny, And
Mhm.
her mom had to have all cesarean sections, and she doesn't really tolerate the pelvic exam really well because her pelvis feels a little platypulate or flat. Then you start to think, you know what, maybe her pelvis isn't shaped in a way that's going to accommodate the size of her baby.
And
It's
is
not.
that when you say, okay, let's just do a cesarean in that situation?
In that situation, you have to check the boxes for several different things, right? And then you can make a decision to do a cesarean section based on failure of for fetal to descend, and that could be due to the bony pelvis not allowing the baby to get past a certain part or a
Right.
certain level of the birth canal.
Right. And all of this is again happening. This is just nature until the head crowns, I guess that's what we call it.
Yes.
I don't know if that's what you all call it. Nature is doing what it's doing till that point. So I saw somebody ask, why not just do a C-section immediately? I don't know if you missed this part, but the physician has to maneuver the baby back through the birth canal opposite the way it came down to get it back. Does it go back into the uterus,
So
ideally?
yeah, well, you want to get it beyond that pubis. You want to get it as far into the birth canal as possible,
Okay.
essentially, and
Okay.
then make the internal rotation. You want to get the baby's head back flexed and pushed as high up as possible.
Got it.
I mean, it's still partly in the uterus already because the body
Mhm.
hasn't been delivered, so
At the
it's
point,
still being delivered all the way.
at a point, and this may not be the same, I don't think it's the same situation. At a point during my delivery of my son, I ended up on all fours.
Mm-hmm. Mm-hmm.
Okay.
That's the Gaskins maneuver.
I have no idea why. I don't know what was going on. Um, it was
So
a lot.
that's, you know what, probably there are a couple of reasons why you would go into that maneuver, and that is if you've been in labor for a while and they're trying to get him to get into the right position. So when you go on all fours, it opens up the sacrum, that space there, so that the baby can descend and get into the right position in the birth canal.
Got it. So all of these things are happening, and I think I hear you saying that it's rare. This is a rare occurrence, and that everybody has trained for this, but
Mhm,
it's
mhm.
I'm making this this is me making a legal conclusion. It's very likely this can be any physician's first time actually dealing with this in real life, or this is not something that physicians see often, if at all.
Yes, so there's a yes and a no to that.
Okay,
And that is in training, you normally see enough shoulder dystocias to know what that's like and how to manage it. Whether
okay,
you are actually doing it yourself or if there's an attending who's doing it. Sometimes, if depending on how serious it is, if you're a lower level a resident, like level 1 or 2, then you may not be given the grace of having 4 minutes to try to get the baby out if you're learning how to do this in a training situation. So most have seen it at least a few times in residency. as an attending, the literature says that it's like 0.3 to 3%. That's
Okay.
how common it is. So it's not really common, right, to see it to your point. That's what the literature says. However, there it's subjective. A shoulder dystocia can be subjective. So there's some data that supports the idea or the concept that if you think you have a shoulder dystocia and you call it out and your designated person starts keeping time, because that's what happens, you have to start timing this, and you can relieve your shoulder dystocia in less than 60 seconds, then that may not qualify as shoulder dystocia.
Right, right,
But it might have been, you just have been very effective in removing it, in
right.
relieving it.
Because you don't
So
wanna take 5 minutes. You just and 5 minutes is that the how long the baby has for viability, or what is the 5 minutes all about?
that's when you have severe increased risk for asphyxia,
Okay.
because the baby's just been sitting right there on the period,
Between
yeah,
yeah,
between, and there's possibility for compression of the umbilical cord. And that if that's compressed, and if obviously that prevents the baby from getting the blood flow with oxygen attached to it.
right. Okay. So now let's go back to all right, you've done the cardinal movements in reverse and you've gotten and so now you use the word other than cesarean, something?
Hysterotomy. Yeah.
Hysterotomy. So that sounds like hysterectomy and something else combined. What exactly is that and how do we end up with a baby not in the mother's body at the end of this situation?
So, so actually, a cesarean section is in essence a hysterotomy. You make a hysterotomy to do a cesarean section. So a hysterotomy is just an incision on the uterus.
I see.
Yeah. And so the uterus is the hystero part, anotomy is opening. So hysterotomy is the opening in the uterus, the incision. So you can deliver your baby through that hysterotomy, and you're doing a cesarean section that way. You can
Got it.
create a hysterotomy in theoretically, because it sounds very difficult to do this, thinking about how this would work, but theoretically, you can go in and rotate the baby and have a vaginal delivery that way. But thinking about the logistics of all of that, I mean, to actually do that, it's very daunting. I can speak about this very casually, but in the moment, in the heat of the moment of having to do something like this, in a matter of seconds to minutes, it's not this well put together in thought. It's a
Right.
thought, but the practice of actually doing that it sounds very daunting to be able to create a hysterotomy and go in and turn the baby internally within the uterus through the hysterotomy, and you have all this bleeding going on.
And do you have to are you leaving the cute room with the TV and dad and everybody in the video camera and getting down to surgery somewhere in this process?
Yes.
So
So
we're going down a hall on a gurney,
yeah.
crowning oh, Lord have mercy.
Mhm. Yeah.
Okay.
At least, yeah, situations like this, you would be rushed. So every labor and delivery has at least one or two um, ORs. So you're
Okay.
not going like down the elevator
Okay,
and
because 'cause I'm like,
tossing
"What?"
in,
Okay, all right.
taking the subway. No, you're not doing all that.
Okay.
But you are gonna, you have to run down the hall with everything, the consent of
Get
the
scrubbed
mom,
up and all of that.
scrubbed up. In these situations, your scrub is probably gonna be about 10 seconds. I mean, you're trying to go and save a baby, so it's gonna be
Mhm.
quick.
Okay.
Um, and consent the mother for the procedure, make sure she has a catheter inside her bladder, so that's protected. And then anesthesia. So in
Oh, yeah.
emergency situations, moms have to go to sleep, and no one else can be in the room.
Traumatizing. Okay.
It's traumatizing. So everyone's adrenaline, everyone involved in this, they're trying. You have your surgical tech who's trying to get their instruments out. You have your physician getting scrubbed up and getting garbed, getting all the attire on so you can have a sterile field. You have your your circulating nurse running around making sure there's all the IVs and sutures and things like that. You have your anesthesia at the top of the bed, making sure a patient's taken care of, okay, making sure the patient stays alive. right? They're
Yeah,
ready to put the patient asleep, so we have to make sure they stay alive. You have your pediatrician coming into the room with their team, ready to do any necessary resuscitation on the baby. So you have all this going on in like minutes.
got it. Got it. So I want to move the conversation a little ahead. It's 9:47. I don't know how long we have you, but this is so rich and dense that it just wasn't something we want to just rush through. And there's so many comments that I also want to address as well, if you have the time. So you'll let me know, kick me or something if you want to wind it up. But when we had our conversation about it, you guys see what I mean about the way she can explain medical things in a way that you're like, I never knew all of that went into it. And you end up understanding it after it's been explained. Because like I said, I've had 2 pregnancies, 2 children, and nobody ever explained what I went through till just now. I had no idea. And there's even a mother in this comment who's saying, my OBGYN, Althea, my OBGYN pushed our last child back when she was crowning and told me not to push. She was maneuvering our baby, then told me to push after about 1 minute. That seemed like forever. I never asked her what happened and never considered it could be something so serious. That is why I thought this conversation was needed, because I don't care how many children you've had, and especially our parents, they were just put to sleep and we were delivered. You don't know what's happening. We don't know I didn't know at what point God takes over, then the doctor takes over. I even had an opinion that my nurse basically delivered my first child, and the doctor showed up at the end and just caught her, because so much had happened prior to that. So this is really needed and helpful, because I understand better now, even further than our conversation on the phone about this, at what point um, medical intervention actually does come in when there's a delivery, and it's not the whole time. As the mother, we're thinking, I need to get to the hospital. Can y'all tell me when I'm having my baby? And they're like, your water hasn't broken. I'm gonna go have lunch. We'll see if it happens. And it's really just, you'll let us know. You and your body, will let us know. And as a person, the person having the baby, you don't know, and you're just kind of, hey, bring me some chicken. you know, and I'll just be here until they tell me I'm dilated enough, and we all know that we don't have any control over it. And again, we're not talking about a specific case, but this is what opened my eyes to go, well, the doctor is in no more control than the mother was. Stuff was just happening, and then the reaction had to come into play and some decisions had to be made.
Mm-hmm.
And I hadn't thought about it that way until you explained it to me. As far as the amount of decisions that the physician has to make based on whatever they walk in and are faced with, literally a face, right? All right, how are we going to do this? Monica saying, my jaw is on the floor. I've had 2 C-sections. First one was an emergency during an ECV due to him being breached and his heart rate dropped. Yeah, I mean, and we all have these stories, and I want to segue to sort of that. Depending, you can tell me how long you want to stay with us. But if we could do like 20 more minutes, then we can maybe do about 10 minutes about advocacy, because I say all that to say we don't know what's actually happening, and we're relying on our physician to have the right bedside manner, the right compassion, the right knowledge and willingness to listen to us, not knowing what we're talking about. And this is not just in the midst of childbirth, but this is period. If you're having fibroids, if you're having pain or pain during sex, or just all the different things that may come up as a visiting with your gynecologist. We'll kind of change it to the GYN part of your background. And or they ask you, okay, how many sexual partners do you have? What happens if you lie to them? Right? If they say, are you using protection? What happens if you lie to them? Like what are and you're in the doctor's office and you're getting ready to have your pap smear, what are the things that really we should be honest about? What are the things that will help us get better care? And then from that, what are some red flags maybe? Because again, we talked about it. There's and this is a compound question. I realize that there's a viewpoint that Black women aren't listened to as much unless our doctors are Black and women. So a lot of us prefer Black women to be our doctors, which is wonderful. But when you don't have that, how can you kind of level things out for you in your care?
Yeah, that was a lot, and,
I know, and I can go back through them in steps if I need to.
so I'm gonna try and touch everything, but let me know if I miss something.
Okay.
Um, there you know, there are a lot, but there when I approach medicine, there's an art to it, and then there's a science,
Mm,
and you can't have one without the other, in my opinion. And then there's a partnership. Uh, I'm helping you, and then you're gonna help me help you, and we have to work together. I make recommendations on what I feel is the best thing to do in your best interest, and then it's gonna be your responsibility to follow through
mhm.
and to ask questions if you don't understand. So it's a partnership, not and I keep that as like the foundation for how I interact with my patients because what's most important is your patient-physician relationship and building that trust so that the patient understands that you have the best interest in mind and you know the patient is doing the best they can. So you're meeting them wherever they are. That's really what it is. So in situations, so I can even bridge what we were talking about to GYN too. But when you're prenatal care or preconception care, because you're thinking about being pregnant, getting pregnant, or you are accompanying your niece, your daughter who is pregnant or thinking about being pregnant to their doctor's office, what types of questions do you ask? And be
Yes.
honest. The honesty is really important. So for this, any kind of news headline, if that triggered you in some way and you're fearful, you can say that, I'm hearing about this maternal health issue with Black women, and I am terrified about getting pregnant because I don't feel like you're gonna listen. I don't feel like my doctor's gonna listen to me. Or I don't feel like the people in the hospital and nurses will take care of me. My previous pregnancy or my previous experience after having a hysterectomy, I kept trying to tell people this was going on. They didn't listen to me. So
Mhm.
when you have or establishing yourself to get care, just be honest. Be honest about your experience in healthcare, what your concerns are, and then your physician can meet you where you are.
Got it.
And they'll have a context on how to communicate with you and how to stop and pause and say, did you understand what I meant by that? Because that's really important. Um, there are times when I go into a patient's room and they are here for a physical complaint. Maybe they're having that normal vaginal discharge or something. They need to talk about birth control methods. But once I get into the room, we're having the banter and we're talking, and then I realized that, say for instance, they're overweight or obese. I personally don't tell someone that because they see themselves in the mirror every single day. I don't have to tell you that. You already know
You
this,
already know.
and so I'm not going to shame you for that. My job is to understand that's a symptom of something else, either miseducation about how to eat. Um, Barriers or access issues to healthy foods, like if you live in a food desert,
Mhm.
uh, could be medical problems, thyroid problem or something. And you know what? Maybe you are 100 pounds heavier a year ago, and you are doing your thing. And but I won't know that if I walk into the room and immediately start talking to you about something that you're so proud of, right?
So now it sounds like an episode of My 600-Pound Life when Dr. Now comes in and goes, "Why you eat the Doritos?" And they get upset. And
Right. Where you gonna put that?
who bring you
But
the Doritos? If you're not gonna be talking to me in a kind of way, Dr. Now, that's okay. Got it. His bedside manner is horrible, but it makes for good TV.
there's a reason for that emotional response to that. But when I sometimes I'll see a physical issue, but when we start talking, I understand that there's so much more to it, right? It could be grief going on. They're grieving the loss of a loved one, or um,
Mm,
they're grieving the loss of their job. Grief
mm.
presents itself in different ways, and so the conversation goes there. And I feel like they get more from the visit from that conversation than what they came in for. So it's really about building those relationships and being honest and with your physician to let them to help them understand the context of where you're coming from.
So let me ask you this. and this is not even really a question, but if I'm in the not the gurney, the stirrups, and I'm waiting on, my pap smear, and you walk in with your smile and you're talking to me and you're trying to understand me and what's going on, I'm going to be open with you. But if this guy walks in and he's got his clipboard and he's not saying anything and he's not even looking at me,
Mm-hmm.
I'm not
Mm-hmm.
going to say anything. And I've experienced both. Um, so it's not a question because it's not something you can answer or anybody can answer. But just like with lawyers, if the lawyer shows up and they're wrinkled and late, you're not going to feel as confident as if you've got, somebody who shows up polished and on time. So a lot of us that have had negative experiences haven't felt like, um, and this is how we feel. This is not necessarily what's going on, but that the doctor is either overworked or not, just happens to be on duty. A lot of times you don't know the doctor that ends up delivering your baby because of rounds and duty,
Mm-hmm.
scheduling. And you should know that whoever's doing your pap smear, I mean, unless you're in some sort of group thing, you should know who you're seeing when you go in, I guess, for your physicals and your checkups. But it's wonderful to hear the way that you approach the patient, and you're thinking about they might be having grief, they might be having a job loss, they might have a lot of things going on that's got them in this situation, and we're not going to even dwell on that. We're going to just get to the solution because I understand. That is why choosing your physician matters to me. Um, and you can feel it. You can feel the clipboard guy who just next,
Yep.
um, you know.
And that's hard because, and it's a systems issue because the physician is challenged with having to meet quotas or having to see a certain number of patients a half day in order to meet target goals that the healthcare system may have or may not have placed on them. And so there's a finite amount of time that you can spend with your patients. And it's either the clipboard or the computer. Everyone's walked in and your person is like,
Mm-hmm.
blah, 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 blah. And tell me about the last time and your last menstrual cycle. And then, and
Yeah.
that's it really. And they do their pap smear and they leave.
Yep.
And then the nurse comes in and it's efficient sometimes, but you may not get what you need. So sometimes in those situations, you can come in with your list of questions. So
Okay.
have a preset list of questions because sometimes those visits can be so quick and the unexpected can occur. And in terms of you not thinking, oh, you may get caught off guard with the pap smear or something else, that happens during the visit. And you might forget your questions that you were thinking about asking. You walk out the door and you're like, oh, I
Oh
forgot
man.
about that
Okay.
headache I've been having and what I should be taking for it. So
Right.
write questions down before you go into your office visit. Always, always, always do that because that will help you um, just stay on task for what you need to get before you leave.
Got it.
If
And do
you're
you give those to the nurse along the way, or do you wait until the doctor comes in and give them to the doctor? I know at the end the doctor always says, "Are there any questions?" Is that when you hand it to them?
You can do both. You can make a copy, give one to the nurse, she'll put it in your file, and then when the doctor comes in, you can ask the questions when they say,
Okay.
"Do you have any questions?" Another thing you can do too is just listen to be engaged in the conversation, whether it's 2 minutes or 15 minutes, but really engaged and to the point where if you hear a word like distortion, and you don't know what that means, then say, I'm sorry, I don't understand what that means.
Yeah.
And let them take the time to explain it to you. Um,
And
if
one of the
you
reasons that I've been candid when I don't understand what you're saying, it is because I want people to understand that it doesn't matter how smart or educated or whatever you are. If you don't know, you don't know. And it's okay to admit you don't know. I'm happy to sit here and say, I don't know what you're talking about. I don't know how you pronounce that word. Help me. Because everybody needs help understanding things that they've never come across. So don't be ashamed to tell your doctor or nurse that you don't know, because why would you know? You know?
Exactly. And if I was sitting in a room of lawyers, I would be so lost because if you all were talking in the jargon that you're used to speaking in, general statute 25467 8, and I'm like,
Exactly.
what in the world is that?
Right.
So
Right.
it's jargon. It's career. That's why you train to learn how to do these things. So it's
Right.
not a matter of inferiority in with your intellectual abilities. It's actually it shows a level of intelligence when you stop and say, "Wait, I want to understand." So
Right.
I need you to slow down. If you're going fast, hold on. You just said something, and I'm not understanding what that means. Do you mind
Right.
taking a moment to explain that to me?
Right.
And if you're having any kind of procedure and they're going over risk, that's important too.
That's
You want
true.
to understand what that means because, and I'll tell you this, we go through risk and procedures for procedures all the time, and it's like rote memory. And it's easy to get caught up in just blah, blah, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I mean, you're just going through the list of things you have to say. And if you're not being present in the moment, sometimes you'll pause, or I would pause and say, well, really listen to this because this is important. You're at increased risk for X, Y, and Z.
Got it.
Um, but a lot of times patients may or may not listen to those risks, and if something happens, it's like, well, we talked about it, right? And
Right.
you're like, well, I don't remember
It
talking
didn't
about
land. Hmm.
it. It didn't land. So, a couple of things too to improve our overall health. Well, for advocacy, you want to advocate for yourself. That's being engaged in your own health. That's talking to your physician, your advanced practice practitioner, whichever it is that you go to. Having a real honest conversation. If you don't understand something, ask for clarification. Write down your questions before you go in. If you don't feel comfortable, take a friend, take a loved one that you trust. Hey, can you go in with me to my doctor's office? Sometimes I get nervous. Sometimes I just need some support. Do you mind doing that? If you Here are some situations too, and I'm going to be very delicate with this because it's 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 not something you just do just because. It's in real situations, like when there's a need. If you're in a hospital, you have a loved one in a hospital, you are the only one there. You're not understanding the medical jargon when the physicians are doing the rounds in the mornings, and you don't really know what's going on with your loved one. Call a friend or a physician friend or someone who can advocate for you on your behalf. I've done that several family members. I'll be on the phone and I'll just, they're the physicians given explaining the situation, and I can stop and ask questions, and I tell them I'm just trying to understand so I can help the family understand what's going on. And
Hmm.
I could say too, but
Yes.
yeah.
Yeah, we have in our family, our my aunt is a respiratory therapist, right? A respiratory therapist. And throughout our whole life, I don't care if we're in there for a ingrown toenail or psychiatry, a psychiatric break, we're calling her and we're having her listen in and explain to us what's going on. It is never
Right.
anything to do with, pneumonia or anything that's in her field. But she has always been our go-to, our advocate, just like they'll call me from anywhere with a legal question. So,
Mhm.
this is why it's important, Dr. Tia, to put our faces on the screen for people to see us. We are here, we exist, we're in our 40s and 50s. We're not 80 and we're not teeny boppers. We've been around, and there's a whole cavalcade of people just like us coming behind us. Things have changed, right? And you can advocate for yourself. Your health care providers and the legal field has changed. And there are opportunities for people to feel more protected
Mhm.
and related to in their interactions with both the medical and legal field. And that is why I think a seat at the table has been um, helpful to the almost 2,000 people that have joined it so far, and why I keep doing it, because it literally is. Now we had a seat at the operating table,
Right. There you go.
right? And we understand the miracle of life is where I came across from out of this. I'm coming out of this with, it is a complete and total miracle, and you're part of that miracle as the attending physician, and a lot of it is novel, and
Yeah.
you don't know what you're walking into at the beginning of the day.
Mhm.
But one thing that I left that conversation no longer feeling like people don't care.
Right.
I'm just being honest. Because why would they not care? Why would they do this if they didn't care?
Right.
Um, and I had to check myself there because, again, I'm coming into it from, and I don't do medical malpractice. I've done one. That was enough. It's not my thing. But one thing I was mentioning about from the legal standpoint, and then we'll take some questions, some of the questions that are here, because there's a lot, and I'll let you. I don't know if you can see them on the side of the screen if you want to scroll through and determine which ones you'd like to take, because I don't think you can even take all of them.
Okay.
Is if I'm a lawyer and I'm approached with a case where something's gone wrong and the family wants to sue, and I understand this is triggering for some of my audience. You've gone through something and it's the hospital's fault or it's the doctor's fault, and that's just all there is to it, and that's how you see it. I respect that. What the lawyer has to do, though, is find a physician similarly situated to the one that you believe caused you harm, and they have to testify as an expert to what has happened in order for you to even be able to file that lawsuit and certainly to be able to win. You cannot, a lawyer or a person who feels they've been harmed by a medical procedure can't just win a lawsuit without that expert on medical malpractice.
Right.
And probably on wrongful death as well. I've not done a wrongful death. And I understand after this conversation why, because it takes someone similarly situated to that that OBGYN to say, here's what she was attempting to do. Here are the steps that had to have gone on here. Whereas I just went, oh my God, decapitation, was the word that came to my mind. And the word that came to your mind was loss of a baby.
Right.
Both are true, right?
Mm-hmm.
Allegedly, because I'm a lawyer. So I have to say
Right.
allegedly.
Allegedly.
But it's being similarly situated and understanding everything that goes on to get to the point where the baby was lost.
Right.
So that is what I hope, we accomplished here today. Again, we weren't and aren't talking about that particular case because neither of us has any idea what actually happened. But I just thought the perspective of understanding all the things that can happen, it checked me. It helped me to be more, it's not that you were checking me per se. It was like, you were like, hey, think about it. Let's think bigger, let's think about it. It helped me to understand how this could happen. It even helped me to understand how, just advancing that story a little further, when there is a loss of a baby, how the baby's presented to a family in a way that's not traumatic, as opposed to propping a body part up, right? Which makes no sense. But when you think about it, how can I present this to you in a way that you get a chance to have a moment with your baby, but we're not traumatizing you? Okay, that makes sense.
Yeah.
That makes sense. And I also did a little research, just trying to understand when there is a loss of a baby, because there was one of the allegations in that case was that the medical examiner wasn't notified. And this may be something you want to speak to or not speak to, but there's a certain point when it's not considered a birth. There's no birth certificate, so the medical examiner doesn't create a death certificate. So there's no reason to notify. It becomes a mortuary issue, because if someone isn't born, there's no birth certificate, there's no death certificate, there's no medical examiner. And again, that's not some, it sounded to me like some kind of cover up, but it's logical. When I took the time to do the research, it was more logical. So I just wanted to put those points in there, not really relevant to anything you need to speak to unless you just have an opinion on it, but just the rest of my understanding after I started trying to actually look at this to understand it. And
Yeah.
so, my original opinion of that particular case, not knowing any of the facts, is that it will settle. I still think it will, because it's just traumatic, unless they just don't get an expert who can look at the medical records and say something happened here. And that's the part I didn't say. You don't just get a medical doctor or someone qualified as an expert in general. They have to look at the records in your particular case, review that, and say something out of the norm happened here. There was negligence, there was gross negligence, there was whatever the standard is for the type of lawsuit you're filing. So it gets tough for us as lawyers, and I don't mean to, this is not like a pity party, but it's really tough when a family comes in and they just know that but for this hospital or this doctor, their child would not have, whatever the situation is, when the medical records aren't there, as according to your expert. They're saying this wasn't negligence. This was not a mistake. This was, you know, just one of those things. And it's really tough to digest that. And it's really tough to explain that to a family. And this conversation, like I said, hope to serve as a way to, if somebody ever is in a situation where they have to have that conversation, they can at least listen with a more open mind and advocate for what is needed for themselves. I have a friend who just had a baby this past week, and her blood pressure was spiking. And it became a thing of the doctor being more like you and saying, I'm not sending you home with this blood pressure and some blood pressure medicine. You're staying here till we get it down. Even after we get it down, you're staying here. And, just being careful as opposed to sometimes we feel like they want us out in 48 hours, I don't care what. And even when she came back on a scheduled C-section, had her son, healthy baby boy, a week later, they kept him an extra day because the doctor was, like you, like, I don't like the way his skin is looking. Let's just hang in here a little more, and I'm not going to send you home without him. So, you know, this is what I hope we got out of tonight. And I'm going to let you take whatever questions that pop out on the screen to you, because that's how I normally do it. I can't answer all of them, but if I see some that I can answer, then I do.
I'm looking for some. I don't see any from my end that we haven't already addressed. Do you see any?
I think I saw one. She said I had an episiotomy to get the baby out. Is that still done?
Yes, yes, yes. Where is that? I don't see it. But yes, that is the episiotomy is where you can make an intentional incision down the perineum. So remember this perineum that we're talking about right here? Yeah, that one right there. We can make an incision down that on the mom's perineum, and that can open up some space too. So that is still done to help with the shoulder dystocia.
What
Mom
is
can end
that?
up with a fourth degree laceration, meaning that there's a laceration through the vagina all the way down to the rectum. And so that can be a nice long recovery period. But if your baby gets delivered and it's healthy, you don't really think too much about that.
I have
Sometimes
never thought I was going to die until after my episiotomy, like 2 days later, the pain.
there's pain there.
Oof.
There is pain there. Absolutely. But it heals over and you do fine.
Yeah.
I want to thank you, Dorna, for being open-minded and delving into the conversation. When we had our initial discussion about it, it really wasn't. It was so natural, and our flow
Mhm.
of our conversations are anyway. And you were truly interested and curious about, okay, so how does this really work? And what are the other nuances there? And that to me is the epitome of someone who cares,
Yeah.
right? And uh, who who's looking for the bigger picture, right? And understands that you know um, there isn't. It's not always just black and white. And so you
Right.
stretch and think about it that way, and it encouraged me to continue to share more. So it's that engagement, right? Oh, I'm
Yeah.
interested. Let me tell you more about this, because I can talk about this all day. I love it.
Right.
And I
Right.
love talking and explaining and teaching. And so I can do this all day long. And you're like, oh yeah, give me more. I'm like, cool, okay, let's talk about this example. Okay, this can happen this way. But I enjoy that type of discussion that we're able to have, and I'm able to understand where you're coming from too. Well, this is what it says, and this is what it means, and this is how you proceed forward from here, and how you're
Right.
able to fast forward this whole process and lay out the scenarios of what can happen legally. I can
Right.
appreciate that.
Right.
And when it comes to the malpractice, any malpractice case, both sides will get their physicians to look at it and kind of figure out what went wrong, what didn't go wrong. Um, and it's I think that the biggest thing I want to take away, I want everyone to, well, one big point I want everyone to leave here is that leave from this, take with them from this talk today is that we're human beings having this experience, right? And think about how information that you receive, how it affects you, and how it affects what kind of emotions it uncovers, because that can help you navigate what to do next and how this applies to you in your life. So, for instance, if you read that headline for this one particular case and you were fearful or enraged, or, again, probably a lot of fears behind that, because you're afraid of what can happen to you, your loved one, if they're ever in a situation like that. So, what do you do with it? You have honest conversations with the people who you trust who are taking care of you. Tell me what my delivery plan is going to be if X, Y, and Z happens. How are we going to process this? So you listen to me if I decide that, once we get this far, I don't think I want to have a vaginal delivery anymore. Like, let's talk about these things, and that can help you relieve your anxiety about that situation because it's triggering. So just think about how we receive information that's presented to us in the world. Um, Take some time to be intuitive and work on how does that make you feel, and then be honest with yourself and take the right measures to talk to the professionals to help you work through it and process it. So
That is really the point of it. Because I will promise you, just like sitting with me at the table weekly, roughly, is the most interaction that most people have with a lawyer because of cost, right, and access. This is the longest conversation that most of us have had with a physician because of time and availability and the way your natural way of I started out by saying you know so much stuff. You just know so much stuff. And you don't really have a use for it until somebody like me says, tell me more. You're like, oh, okay, I could talk about this all day. I felt like the table was a good place where other people would go, I could listen to this all day. I mean, even some of the comments are, I will be rewatching this. So good. um, Thank you both for a clear, concise conversation. There's so many educational gems here. Well done. And I know there are so many more comments that are like that because this is good. This is good. It started out, like I said, about a situation, but I think we've all come away now understanding things that we've done, like have children. We don't even know what happened. Now I understand. I might go down and say, you know what? Let me tell you what happened when you were born, because I never understood it till just now. you know. Um, and it will give us a basis to be able to know to write our questions down when we get ready to go to our doctor, to bring a friend that we trust. But I just want to, again, I'm always at the end of the story. If you are in a domestic violence situation or a situation where you are maybe married to a narcissist, or any number of things where you don't feel like you can be honest in front of that person, please don't bring them to your doctor's appointment, so that you get this opportunity to talk to your doctor and
yeah,
be honest about the help you need. If it's with domestic violence, or if it's more personal, I mean, that's personal, but something personal, this is an opportunity to get in the room with somebody who can advocate for you, who can help you. Um, and they can always, correct me if I'm wrong about the methodology here, Tita, but they can always make it appear that they need to talk to you privately.
yes,
Okay, so that's the other thing I wanted to just get out, is that sometimes with the lawyer and the doctor are the only two places where a person can just be honest.
hmm hmm
And we have taken oaths to step in at certain points. So take advantage of that. If you need help, if you need men and women both can be abused and mistreated in relationships. I'm talking to our whole audience here. If you need a ear that has an obligation to do something, when you tell them certain things, talk to your doctor or your lawyer, and then that can help you. That's the other thing I just wanted to get out before we go, is that, that obligation that we're under.
Absolutely. And actually, in some medical practices, there are methods for you to communicate privately and separately. So some places, when you go and give your urine in the bathroom, there'll
Mm.
be a pen that you can write with in green or different color, or maybe you can do something special. They'll have a note on the door where you drop your urine that says, "If you are in a domestic violence situation and you need help, then let us know this way." And so that's a private way to let the team know that you need some help, and they can do this for you. They can provide you the help, especially if that person is with you during a visit and you don't have any other way to break away from them to share that and be honest. So practice some medical practices do that, and I think that's really helpful for women who are in those types of situations.
Yes, yes. I've seen that as well as in the airport or restaurants near the airport, where they'll say, if you're a victim of human trafficking, do this or call this, or, so most of us are too old for human trafficking at this point in our lives, but we are
Yeah,
in situations where we just need a wave the flag and just say we need help, and we don't feel honest, or that we can be honest in the room, because that abuser may be sitting right there looking at them like, don't you say anything. So yeah, we just wanted to get that. I wanted to get that out as well. I appreciate you, Tia, and all of your knowledge and your time tonight, as well, sharing with us. And I appreciate the audience. You guys have always been great as far as asking good questions. You came with your open mind. Um, like I said, we weren't here to try case. We were just kind of trying to expand our understanding of what in the world could have happened possibly here. And so I appreciate that, that you all received my guest so well, tonight. And maybe there'll be some other opportunities where we'll bring you back and talk about some different things, you know, that could be helpful,
I
if
would
you're
love.
willing.
Yeah, absolutely. I would love to. Thank you, everyone, for the warm welcome, and thank you, Dorna. Dorna is like a big sister to me. She knew me before I went to medical school, and so she's always been an inspiration to me. And talk about knowledge. She knows a little bit about everything, so much, and she's just inspired me to be a better person, to think outside the box, to help other people with the skills and the gifts that I have, and to she's someone that just blossoms wherever she is in every situation, and I've always known that about her, and I just appreciate it. So thank you for having me on. It's a huge honor. It's a huge honor to be in this room with everyone, and I look forward to doing this again.
Let's do it. Let's do it. I guess the next time I see you, I'll be standing up for you at your wedding.
Absolutely.
Yes, yes. Looking forward to that. So, all right. Thanks again, Tia. And thanks, everybody. I'm going to end this broadcast. Obviously, it'll be saved here because I'm going to go back and watch it. This is really dense information. And I think, we can all feel free to share this with whoever in your life may need to understand some things that may have happened to them in their delivery situations, that just might have this might clear some things up for some people. Like Tia said, a lot of times we carry around grief and we don't even know what we're upset about because we don't even understand the thing that happened. And this could be a way to help somebody move past something if it helps them to understand what could have happened and where God took over and where medicine kicked in, right?
Absolutely.
Okay. All right. Well, I love you, Tia. You
Love you
guys
too,
have a good
hon.
night, and we'll see you next week. I'll figure out what we're talking about between now and then. Bye.